Thank you for the invitation to speak here. Kia ora katoa katoa. I'm a 64-year-old Pākehā cardiovascular disease epidemiologist and public health doctor. I co-direct a big data research program in vascular health. My co-director is Martiri Harwood, and I take the principles of the Treaty of Waitangi very seriously. Martiri, you'll be pleased to hear I can tell the difference between a Māori and an Ethiopian, despite the fact that I went to Auckland Grammar School, because I actually was born in this little place called Te Kaupuru, which was 10 miles down a metal road from a little town called Dargaville, and I lived on a farm which was 5 miles down a dirt road from Te Kaupuru for quite some time, so and which is not far from where you grew up. Yeah. And actually my father, well, it was your grandfather, he didn't tell me that I'd be a doctor. He said that if I was lucky I might own my own rubbish truck, which is kind of interesting. Yeah. Anyway, today my main research priority is achieving equity in cardiovascular health for everyone in Aotearoa. And interestingly, I feel like I'm well qualified to do this work, because I'm a member of a relatively small but highly privileged group of New Zealanders who have, as a group, excellent cardiovascular health. Now, it would be embarrassing if I had a heart attack tomorrow, but I can tell you, based on my own research, my probability of that is quite low. But anyway, that's me today. But 38 years ago, well, it will be 38 years ago on the 1st of December, I started my career in cardiovascular disease epidemiology. And back then, my main passion was primordial prevention. Now, you've all heard of primary prevention. Many of you will have also heard of primordial prevention, which is to try to stop the development of risk factors before they even start. Because even back then it was clear to me that the origins of atherosclerosis started in youth, if not before. And they were related to dyslipidemia, they were related to smoking, they were related to high blood pressure, high blood glucose, high BMI. So back then it was very clear to me that the focus should be youth. And actually, I better put the timer on to stop myself raving. And I was passionate, particularly about smoking, and I was very fortunate to work with Robert Beaglehole, who, more than any other New Zealander, was the person who convinced Helen Clark to introduce smoke-free legislation. And we were so focused on prevention and stopping kids starting smoking that we dismissed our colleagues who wanted to put resources into smoking cessation, who wanted to put resources into what were then very expensive cholesterol-lowering and blood pressure-lowering drugs, and to put resources into cardiac bypass surgery. We felt that far too much resource went into those areas, and it should all go into primordial prevention. A couple of years later, so soon after Helen Clark introduced the smoke-free legislation, I was at an international conference on smoking and health, and the keynote speaker, who's now Sir Richard Peto, he was Richard Peto back then, he made the statement which changed the way I thought about prevention, and he said, in the next 40 years, by far the majority of smoking-related disease is going to occur in people who are already smokers. And anyone who has any interest in public health has got to be extremely interested in smoking cessation. And I'd spent the previous 10 years completely dismissing smoking cessation. I was so passionate and focused on primordial prevention, but he made me stop and think about my work, and so the title of my presentation here is different from the title of a presentation I would have given 38 years ago, even 30 years ago, and well, there it is. And to summarize what I'm going to say is that if the question was asked of me, who should we spend the next dollar for cardiovascular disease research, and I do specifically say cardiovascular disease research because it's not the same with all research, but where should the next dollar of cardiovascular disease research go? And I would put to you, with deference to those of you who work in fetal health and in early life, that the likely benefits to be derived from investigating intrauterine and early life determinants of cardiovascular disease will be limited compared to the substantial and more immediate benefits likely for investigating how best to prevent and manage cardiovascular disease later in life. So that's a summary of what I'm going to say. And I'm going to give you the main points of this presentation at the beginning, and then give you a bit of evidence and come back to them. So first I have to say that I have no doubt that the origins of cardiovascular disease are in childhood or in utero. I have no doubts about that stays. But despite that, we have to acknowledge, and Tony Blakely mentioned this morning, cardiovascular disease mortality and indeed incidence. Now, he said 80%. It's fallen by over 90% in New Zealand since 1967, when I was in the third form. And it was interesting, our morning tea this morning reminded me of 1967 food. I couldn't eat any of it. But the lunch, I'll be pleased to say, reminded me of the cardiovascular healthy diet that we're now eating. But it was an interesting juxtaposition, and I don't know whether it was done on purpose. I thought initially that it was, the morning tea was given to us by the Better Start, people who thought it was too late by the time you got to our age and that we could just eat crap. But anyway, they certainly came to with the lunch. And anyway, this 90% reduction, which has occurred at all ages, and I'll show you some data, has occurred in all age groups, irrespective of early life environments. So probably the main reason for my statement that there's not much to be gained by doing research in early life is we've achieved a 90% reduction since 1967 without any impact on early life environment. Okay, is this going to work? Yeah. Because of this huge reduction, most of the low-hanging or preventive cardiovascular fruit has now been picked. Most of the remaining modifiable cardiovascular risk is in older adults, and I believe it's possible to identify this group effectively and cost-effectively using high-risk approaches. The other point is that the benefits of intervention in these identified older people actually occur within a few years, even though it takes decades to develop cardiovascular disease. It's almost unbelievable, almost magic, that interventions, if you change your behaviour, if you take drugs, lots of things, you get massive reductions in risk within a few years. It's magic. And that reduction happens in both older and younger people. And so therefore, as a result of those points, I believe that the cardiovascular research priorities should be to determine how best to prevent and manage cardiovascular disease among older rather than younger New Zealanders. So that's my premise. And if I have, I did have one, I thought I had one more. If I have time, I'm going to ask the question, is obesity diabetes, is it an exception to what I've just said? But we'll see. So let's start with this decline in cardiovascular disease. I'm going to show you a couple of slides that they come from this website, which I suggest if any of you are interested in looking at trends in disease in different countries, you need to go to this, www.mortality-trends.org. It was developed by a New Zealander, Gary Whitlock, who was a public health doc who unfortunately died in 2013 at the age of 49 of cancer. But he developed this website. You'll see up here that this is New Zealand Aotearoa. It's the only country where the name is in Māori as well as in any other language, in English, because he was a Kiwi. But there's about 30 countries, multiple causes of death in different age groups, and it gives you data on mortality between about 1950 and 2010. This is 35 to 69-year-olds. There's the peak. There is the peak in coronary heart disease in 1967, increased rapidly up to 67, and it's declined. This is to 2010. It's continued to decline. It's happened at the same rate, believe it or not, men and women. Women protected from coronary heart disease, particularly when they're younger, but the rate of decline is about 3% a year, and it's been the same in both men and women. Started in the same year and has been declining at the same relative rate. This decline has happened, it started in the same year, didn't matter whether you're 15 to 34, 35 to 39, 50 to 59, or so on up to 70 to 79. It was like there was something in the water, okay? Well, it was something we took out of our diet primarily, which is we stopped eating so much saturated fat. But I'm not going to go into that in a big detail. But the key thing is that this phenomena was something that happened to all New Zealanders at the same time, despite their early life environment. Okay, so this was what Tony said before was a period effect, not a cohort effect. If you see a cohort effect, you think early life determinants of disease. If you don't see a cohort effect, you see a period effect, you think that it's something in the environment that's happened to everybody at the same time. So, as I said, this is cardiovascular disease. And for cardiovascular disease, the determinants of disease are things you've been doing in the last 5 years or so, it seems to be. Just one of those diseases. Okay, it's continued to decline. This is data from New Zealand by one of my wonderful PhD students, Karina Gray, who's a public health doc and just completed her PhD. And this is rates of coronary heart disease in New Zealand between 2005 and 2014. The red is mortality in older people, the blue is hospitalizations, and basically it doesn't matter, in everybody, cardiovascular, coronary disease is coming, and all cardiovascular disease is declining still at 3 to 5% a year. Okay, it doesn't matter whether you're young, whether you're old. It's happening in all ethnic groups. This phenomena, this amazing phenomenon, it's continuing to decline. Okay, so here's a disease which has just fallen by so much, and as a result, I believe most of the low-hanging fruit has been picked. And most of the remaining modifiable risk is left in older adults, and it is possible, I believe, to identify these groups using high-risk approaches and to treat them. Now, I'm going to show you data. This is data that comes from the IDI. This is every New Zealander aged 30 to 74 in 2013. There were 2,432,796 of them. And we've applied a risk prediction tool, which I'll show you in the next slide, but we've been able to give every adult New Zealander a predicted 5-year cardiovascular risk using a tool that another one of my PhD students, we've applied it to the IDI. And what you see here, oops, wrong button, is 70% of the population, aged 30 to 74, account for 22% of the cardiovascular events and deaths. Up here, 6% of the population, and these are the ones with prior CVD, account for 34%. and you can see in between the numbers, is that the vast majority of the events actually occur in quite a small proportion of the population. What we used to calculate risk was a tool we've just recently published. Sunila Mehta, another of my PhD students and public health physician as well. We used linked health data, 1.7 million people, to create what we call a policy risk prediction tool. Any policymakers in the room, we've created a policy risk prediction tool that you can apply to the IDI and calculate cardiovascular risk on everybody. And using these data, basically, again, 16% of the population, these three groups accounted for 60% of the events, and 30% of the population, which is these four groups here, 1, 2, 3, 1, 30% of the population accounted for 78% of the events, and 9 out of 10 of those people were aged 55 to 74. So these are the older New Zealanders. The vast majority of events occur in these older New Zealanders. We know from randomised trials that these high-risk older people get the greatest benefit, in this case from statins, and the higher the column, the greater the benefit. Okay, the same with blood pressure. The higher the risk, these people up here, the greater the benefit. So there's good evidence from trials that you get greatest benefit in high-risk patients who generally are older. We know, and this is the magic bit, that when you randomise people to blood pressure lowering or lipid lowering compared to a placebo, you start seeing the separation in the events at 1 year. At 1 year. 1 year after you start these drugs, in this case, standard blood pressure treatment in the blue, intensive blood pressure treatment in the kind of orange, you see the separation at 1 year. We also see that it doesn't matter whether you're under 65 or over 65, you get the similar benefits from blood pressure lowering drugs. When we move to statins, if you give statins to people, again, you see the separation, statin versus placebo. You see the separation within 1 year. You see about the maximum benefit within 5 years. So these things happen rapidly, and it seems to work at all ages. Doesn't matter whether you're under 65, 65 to 75, or older, the benefit is there. Okay, so there's a lot of benefit. Now, I've talked about 30 to 74-year-olds. I haven't even mentioned so far the almost 250,000 New Zealanders who are aged over 75 years. And those over 75 years, they represent 6% of the New Zealand population, and they account for a quarter of all of the cardiovascular events. There's another 6% account for a quarter of all of the events. And my previous slides have shown that we could do a hell of a lot to prevent many of those events. Now, by prevent, we don't cure them. We just mean you get them later, but the death rate is 1 per person. What's important is when it happens. So you can prolong healthy life significantly with different interventions. It doesn't have to be with drugs, but it's changing diet, stopping smoking, reducing salt, we heard this morning. These will all make a big difference in elderly people. Just a point about the over 75-year-olds. And I make this statement here. Current national and international clinical guidelines on the prevention and management of cardiovascular risk in people 75 years and over can be summarised in 3 words: use clinical judgment. And this is criminal, I believe. 6% of the population, 25% of the events, and the sum total of the guidance we give to our clinical colleagues is use clinical guidance, use clinical judgment. Okay, how am I doing? I'm doing okay for time, 60 minutes. Okay, now don't look at the detail, but this almost 250,000 New Zealanders aged over 75, there's a couple of good news, bad news things. The bad news is that, look, this presentation I'm not talking about Māori or Pacific, specifically focusing on, I've only got 30 minutes, but there are only 768 Māori in New Zealand aged 85 years and over. Actually, Martiri, your slide, this is another example of one you showed, really, and Pacific 543. So the numbers certainly over 85, they're mainly New Zealand Europeans. But I want to draw your attention to this thing called the Charleston Comorbidity Index, which tells you a little bit about, do these people have comorbidities? And just to point out, the good news is 2/3 of people aged 75 to 84 have a comorbidity score of 0, which means that they do not have significant comorbidities. And about half of everybody over 85 have a comorbidity score of 0. So there's a lot of healthy people in this age group. So it's not too late. It's not too late to help these people. A lot of healthy people. And the other point, and again, there's lots of data here, but I just want to draw your attention to this line. If you see, this is polypharmacy. This is people taking 5 or more drugs on a regular basis, many of them cardiovascular preventive medications. If you're 75 to 84, somewhere between 55 and 60% of people are taking 5 or more medications. If you're 85 and over, it's in the same order. It's over 60%. And it's a black box, and there's no clinical guidance on how to deal with this. Is it too much? Is it not enough? Who are the ones who are not taking them? Should they be taking more? Should they be taking less? We don't know. The answer is we don't know. We just don't know. So, and I'm going to be on time, so I'll be able to talk about obesity. I've only got 2 slides on that. So I put it to you that while there is no doubt that CVD has its origins in childhood, because of the major declines in this disease, and I'm talking about this disease, we've picked most of the low-hanging fruit. There's a relatively small number of people left with cardiovascular disease, still quite a few, but it's relatively small, much fewer than when I was a kid, and that probably the best way to manage cardiovascular risk in those who still have it is to put more of our resources into a high-risk approach to identify them, because we know that the benefits can accrue very quickly. We know these drugs and other interventions work in these people, and so that's where I think we should be putting our funding. Jim, I'm going to have just 2 slides, saying I thought I was under my time, but I'm going to stop. It'll be very quick. I want to leave you with this: is obesity diabetes exception? Because often when I talk about these things, people say, but there's something different about obesity and diabetes. And we know, for example, that obesity, like if you measure people's BMI in adolescence, it does track into older life. It does track. But all of the cardiovascular risk factors track. But is it different? I would say no, it's not different from any other risk factors. And the reason I say that is that obesity affects the majority of the New Zealand population. So our main target, the main intervention for obesity, has got to be to target the obesogenic environment, not a group, not a specific population group. It should be the obesogenic environment. But a bit like smoking, in the next 40 years, most obesity-related disease is going to occur in adults who are already obese. So if we are going to use targeted interventions, I would put it to you that the focus of those interventions should be adults, not children. Thank you very much.